Right coronary artery anatomy. So again, the inferior wall MI, that is an occlusion of the posterior descending artery. So again, this artery that's shaded a different color that's wrapping around the back of the right side of the heart here, that is supplying the inferior wall of my left ventricle. A right ventricular wall MI would be an occlusion of this marginal branch that we can see here on the front of my right ventricle. If I have, again, an inferior wall MI, so ST elevation and 2-3 in AVF, we will move V4 over from the left side to the right side, and we will rerun our 12 lead. And the reason we're doing that is we are going to see if there's any ST segment elevation in V4R, so a right-sided 12 lead. If there is, that tells me that occlusion or the clot is proximal in the right main coronary artery. So it's somewhere above the bifurcation of my marginal artery and my posterior descending artery. It's somewhere above that, and it's causing effects downstream. If I run my right-sided 12 lead and V4R comes back totally fine, well, then I know the occlusion is not above that bifurcation. My right ventricle is not affected, and the occlusion is somewhere in that posterior descending artery alone. So why is that important? So we have always, oops, sorry, my computer went a little bit crazy there. We have always been told that if we have a right side, if we have an inferior wall MI, move V4 to the right side, repeat it to determine do we have a right ventricular infarct or not. So and this rings true for current protocols and for current national EMS education standards. The thought process behind that of figuring out why is it important is because our right ventricle is responsible for preload. So it's responsible for filling, not under pressure, with an adequate amount of volume and pumping that volume into my lungs where it becomes oxygenated and then goes to my left atrium and down to my left ventricle. So the thought process is if my right ventricle is infarcting, as demonstrated by ST segment elevation and V4R, if my right ventricle is infarcting, it's obviously not doing well. It's not going to be able to do its job as effectively as it needs to. And now with nitro, I'm vasodilating and I'm causing lower pressures, and I'm making that right ventricle's job harder for it to pump blood to the lungs. So that is why we've always, taught to move V4 from the left side to the right side so that we can determine where exactly is that occlusion, or at least with some degree of accuracy, because it's going to dictate what treatment we have for our patients. So we've always treated those patients with maybe hold off on nitro. If their pressure's good enough and you feel comfortable giving them nitro, you can if your protocol allows it, but make sure you have IV access in place and make sure that you have a 500 bag of fluids or a liter bag of fluids ready to go. The other part of that treatment plan has just been a fluid challenge and operating off of Starling's law. So remember, Starling's law is the principle that the harder or the greater you stretch something, if I have a rubber band and I pull it back really far and I let it go, the harder that rubber band is going to contract or going to slap. And that's the theory or the principle that we're working off of with this right ventricular MI and giving fluid boluses, is that we're giving more fluid to the right ventricle. We're causing it to stretch more so that it can contract harder and squeeze harder to move blood to the lungs. So we have always taught it that way, and I'm going to talk about some interesting statistics that are just coming out about that whole process. So I get an ST segment elevation in leads 2, 3 in AVF. Again, we're going to move V4 to the right side. And in this 12 lead, they move V4, V5, and V6. If you saw it real quick, it showed V4R, V5R, and V6R. You certainly can do that, but you also do not have to. V4 alone is 97% accurate in finding a right ventricular wall MI. So you can move V4, V5, and V6, all three leads to the right side and repeat it, or you can just move V4 over, and V4 is 97% accurate. So when I move V4 to the right side, and I repeat my 12 lead, if I have ST segment elevation in V4R, then that tells me I have a right ventricular infarction along with my inferior wall infarction or that elevation in 2, 3, and AVF. So under normal circumstances, that would tell us I need to withhold nitro, or at least be very cautious with nitro. And maybe this patient needs a fluid bolus first so that we can hopefully operate off of Starling's law, cause that right ventricle to stretch more and therefore contract harder. So this is pretty interesting here, and I know there's a lot of colors going on here, but hang with me. And there's also a QR code for this second research study that's in green. If you want to scan it and read it, it's pretty interesting. So the AHA, the American Heart Association, recommends that we withhold nitrates in the presence of a right ventricular myocardial infarction, and that is in both the 2015 and the 2020 guidelines. So that recommendation is based off a 1989 study of 40 patients. The dose of nitro was not captured in that study. So it could have been the correct dose or it may not have been. And the routes were varied between sublingual, IV, PO, and transdermal. So in those 40 patients who were given an unknown dose of nitro via several different routes, 40% of those patients had adverse effects. And what they defined an adverse effect was a decrease of 30 millimeters of mercury or more in the patient's systolic blood pressure. So 40% of patients had adverse effects from that 1989 study. That is the reason that in 2024 now, we are continuing to operate and practice as if we should never, absolutely never give nitro to a right ventricular wall in my patient. And I've taught it that way for years. And I've tried to beat that in the heads of my students for years because they're going to see it in the field. They're going to see it on the national registry, right? And that's what AHA is telling us to do. So in 2023, Wilkinson, Stokes, Betson, and Sawyer, they did a meta-analysis, which is basically just a review of another research study. And that study was in 2017 of 46 patients. Nitro administered to inferior and right ventricular MI patients is more likely to cause an adverse effect, but it's statistically insignificant when compared to other cardiac regions. So what that means is, yeah, if we give nitro to a patient who has both an inferior and a right ventricular wall MI, they're a little bit more likely to have an adverse effect, but there's really not that great of a difference in the adverse effect or the rate of adverse effects those patients are going to see versus the adverse effect that my septal wall in my patient might have from nitro, or my anterior wall or my lateral wall in my patient might have from nitro. So something that all of these studies pointed out is nitro has a serum half-life of approximately 3 minutes. So you'll see some variation there of like 1 to 4 minutes, which is why we say we give it every 5. So it has a serum half-life of approximately 3 minutes. So if a patient does have an adverse effect, if they do become hypotensive or they do become a little bit bradycardic, it's likely to be pretty transient. It's likely to last just a few minutes before that half-life of nitro is gone. So what that 2017 study classified as an adverse effect was a heart rate less than 60, a systolic blood pressure of less than 100, or a drop of 1/3, so a systolic blood pressure drop of 1/3 of its initial value, a GCS decrease of more than 2 points, syncope, arrest, or death. So this study in 1989 of 40 patients just classified an adverse effect of a decrease of 30 or more millimeters of mercury in the systolic blood pressure. This 2017 study actually looped in a lot more signs and symptoms to be an adverse effect in their study, which is good because it kind of further enhanced the point that nitro can cause adverse effects, but it doesn't really cause any more adverse effects in that inferior RV wall in my patient than it does in any other cardiac region. So That doesn't mean to go ahead and start blasting everybody with nitroglycerin who's having a right-sided MI. You obviously still have to go off protocols. You have to go off your medical director's guidance. But really the whole point of me telling you this is I do think that we will see, I don't know if it'll be the next AHA update, but I do think this could change from the AHA recommendation. And I think this could change from a local protocol standpoint, that we may no longer be told to withhold nitrates from that inferior and right-sided MI patient, that as long as we have an IV in place and we have fluids ready, the benefit of nitro far outweighs the possible adverse effects that they could have. So another really interesting thing here was from these studies were that nitro administered to isolated inferior wall MIs, so just elevation in 2-3 and AVF, the right side was fine, had the lowest number of adverse effects. So I think that's important to call out, because if you ask in your firehouse now, there's probably some people that are under the impression that if they have an inferior wall MI, I am just period not giving nitro because of the fear or the worry with that right-sided involvement. What these studies found was inferior wall MIs alone, isolated inferior wall MIs, so that occlusions down the posterior descending artery, those types of MIs actually do the best with nitro. So the patients who actually will benefit the greatest and have the lowest number of adverse effects from nitroglycerin, sometimes those patients don't get it at all because of a fear of right-sided involvement. So it's definitely something to keep in mind and think about as we start to see these patients in the field. So again, that QR code's there. You can scan it and it'll take you to this meta-analysis here. I can also send it out if you'd like me to. Just reach out afterwards and I'd be happy to provide it.